This week we talk about the respiratory system. When we think of the respiratory system, it's actually a partner system working together with the circulatory system, which is the blood vessels, and the main object of the respiratory system working with the circulatory system is to deliver oxygen to the tissues and to pick up carbon dioxide, the waste product from metabolism, from the tissues and remove it from the body. So the job of the lungs is to bring the freshly oxygenated air into the body from the atmosphere and to blow off the carbon dioxide that is delivered to the lungs from the blood. So some terminology just to keep us on track with the respiratory system. Ventilation is just the movement of air in and out of the lungs. So when a patient is on a ventilator, we're assisting with that process of bringing air in and out of the lungs. So that's what ventilation means. And then the terms respiration, external versus internal, is talking about the exchange of oxygen and carbon dioxide across a membrane. In the case of external respiration, we're talking about the exchange of carbon dioxide and oxygen between the alveoli of the lungs and the pulmonary capillaries of the blood. So being a little more specific here, it's when we talk about the lungs, we're specifically zeroing in on the alveoli. In the blood, we're looking at the pulmonary capillaries. So that exchange of these gases we call external respiration. Internal respiration is the exchange of oxygen and carbon dioxide between the tissues and the blood vessels. So we're looking at any tissue of the body and the capillaries serving that tissue. That we call internal respiration. So for this process to occur efficiently, we need a well-functioning vascular system, circulatory system, and respiratory system. So looking at the passageways leading into the lungs, we discussed this in lab. We have the trachea up here branching into the two main bronchi, which then branches into secondary and tertiary bronchi, eventually leading to bronchioles. And remember that the trachea and the bronchi have cartilage holding them open, but the only thing we see in the bronchioles is smooth muscle controlling the diameter of those airways. So we have smooth muscle in the bronchioles, and then eventually leading to the alveoli. And the alveoli, remember, are only made up of simple squamous epithelium, very thin tissue for rapid transport of gases. That's their primary function. And we have many, many alveoli making up the lungs, and each alveolar sac has its own terminal bronchiole serving that sac. So when you look at the respiratory membrane specifically, we're talking about that combination of tissues that are in direct contact with one another. So if we look at the alveoli of the lungs here, we see that they're made up of simple squamous epithelium. We talked about that in lab. And we will talk about, when we get into the vascular system, that the capillaries are also simple squamous epithelium. So when we look at what we call the respiratory membrane, we're looking at this intimate relationship between a portion of the pulmonary capillary and the wall of the alveoli. And we'll remember that we have a blood supply bringing blood into the lungs from the heart, which is the pulmonary artery. So the pulmonary artery is the only blue artery because the blood has not been oxygenated yet. So in looking at this diagram, this is a branch of the pulmonary artery which terminates in these pulmonary capillaries. And then the alveoli bring freshly oxygenated blood into the lungs from the outside air, and that oxygen enters the pulmonary capillary and then is taken back to the heart for distribution to the rest of the body via the pulmonary vein. So looking a little more closely then at this respiratory membrane, we have the pulmonary capillaries. That's what's shown here. This is a cross section of a pulmonary capillary that's surrounding an alveoli. So we have multiple pulmonary capillaries here. We can see the simple squamous cells of the alveoli. And if we look at a side view, here's the wall of the alveoli, again, simple squamous epithelium. And here's the wall of the pulmonary capillary, again, simple squamous epithelium. So it's only 2 cells thick, this respiratory membrane, again, providing a good surface area for rapid exchange of carbon dioxide and oxygen. So we know that carbon dioxide from the tissues is carried from the blood to the capillaries and into the alveoli. So it just diffuses out of the blood into the alveoli. And the oxygen is going to diffuse from the alveoli into the blood to be carried away and oxygenating the tissues. So when we look at the respiratory membrane, we look into an alveoli, we see a couple of different things. We see that the primary structure of the alveoli is made up of type 1 alveolar cells. So simple squamous epithelial cells, one layer thick, and just forming the wall, providing the structure of this alveolus. And then scattered among them are the type 2 alveolar cells, which are shown in green here. And they have a special function. One substance they secrete is surfactant. And surfactant helps overcome the surface tension that we see on the inside of the alveolar wall. And what surface tension is, it's just the layer of water that we find inside the alveoli. The air in our lungs is humid, moist air, and that's important for keeping our lungs elastic. So this moisture, this water that forms a thin layer inside the alveolus can form a water droplet, which means the water molecules on this side of the alveolus would be attracted to the water molecules on this side via hydrogen bonds, and that would cause this very thin, delicate alveolus to collapse. But the surfactant that's released by these type 2 alveolar cells acts like a detergent, breaking down that and reducing that surface tension and keeping the alveoli expanded. So it's very important that we have surfactant production within our alveoli to keep these alveoli expanded and overcoming that surface tension, or that tendency of these alveoli to collapse due to water molecules lining their inside surface. And they also secrete antimicrobial proteins, which just keeps the lungs sterile, because we want a sterile environment inside our body tissues. And the type 2 alveolar cells secrete antimicrobial proteins. And also, if you look around on the inside, you see these blue structures. These are macrophages. These are part of the immune system. They're white blood cells that actively break down and phagocytose debris that might have made it into the alveoli, and again prevents infection. So if we look at a normal chest x-ray showing lung tissue, we would expect to see some hazy whitish tissue indicating lung tissue. So an x-ray will absorb some of that simple squamous epithelium of the alveoli, as well as some of the vessels. Here we can see the heart shows up as a large white mass in the midline. Slightly off to the left here is the left ventricle. So we can see that in a typical chest x-ray. We should see hazy white structure, and some of these darker white structures are the airways that are a little thicker. Remember, some contain that cartilage, so that's going to pick up a little bit of that x-ray. But typically we should see just a hazy white structure. But if we have, for example, a pneumonia, that's fluid in the lungs, we're going to see extra white that should not be there. So if I look at this x-ray here, I can see that there's excess white in the bottom of this right lower lobe of this lung, and that indicates a pneumonia. If I look at this lung, we can see scattered white kind of dense structures throughout the lung. This is an indication that we have scar tissue and inflammation, which is common in people that have chronic emphysema, chronic lung diseases. Pulmonary fibrosis is a real problem and prevents and interferes with that respiratory membrane. So if we have fluid in the lungs, if we go back to our respiratory membrane, if we have excess fluid in between these two membranes or inside this membrane, we're going to see a problem with oxygen and carbon dioxide diffusing if we have an increased thickness of the membrane. So that causes oxygenation problems with these patients. So fluid interferes with the respiratory membrane. Here we have connective tissue, inflammation, scar tissue, again interfering with that delicate respiratory membrane. And here we see a lung collapse. Atelectasis is a term for a collapsed lung. Again, if we don't have enough surfactant production and this surface tension causing a water droplet forces these walls together and collapses those tiny alveoli. So that is what we might see on some chest x-rays looking at the lungs. Fluid in the lungs, scar tissue, inflammation, and then here lung collapse. So looking at the blood supply to the lungs, again, we talked about the pulmonary arteries are going to carry blood with low oxygen to the from the heart to the lungs. So the job of the lungs is to oxygenate that blood, and then the pulmonary veins are carrying freshly oxygenated blood back to the heart. So we see low oxygen in the pulmonary arteries, high oxygen in the pulmonary veins. And looking at the membranes that surround the lung, you recall from general A&P that the parietal pleura is what attaches the lungs to the body wall, and the visceral pleura is what lines the surface of the lung. And in between these two layers, these two serous membranes, we have fluid, pleural fluid, and that helps provide lubrication and also surface tension. These two membranes stick together because of the hydrogen bonding of the water molecules in that space, and that's important in keeping the lungs attached to the body wall, so when we take a deep breath and our rib cage expands, the lungs will follow because of the surface tension in that pleural fluid. So if we look at specific functions then of the pleural fluid, is it provides lubrication and surface tension and keeps the lungs expanded. So if we look in and zero in on some of the pressures across the lung and inside the lung, one pressure we can talk about first is intrapleural pressure. Intrapleural pressure is that pressure that is inside the pleural fluid. And if we look at what causes intrapleural pressure, it's the result of two opposing pressures. And one is the elastic recoil of the lungs, which means that when the lungs are stretched during a deep breath, if we stop that stretch, we relax the muscles of the thorax and the diaphragm, the lungs are going to recoil. They're going to go back to their original size. So they're stretchy is basically what elastic recoil means. It just means that when we stretch the lung, it goes back to its original size. So that's going to decrease the lung size. So this is a force acting inward on the lungs, promoting their collapse. Surface tension, we already talked about, is on the inside of the alveolar walls, and that fluid that lines the alveoli causes a water droplet to want to form, and that pulls the alveoli inward. So that's another inward force acting on the lungs, causing the lungs to shrink in size. But as we expand the chest wall, when we work the muscles of inspiration, we see that the chest wall goes with the thorax, which is the rib cage, and that's an outward force. So the elasticity of the chest wall pulling on that parietal pleura is going to pull the lungs outward. So the two inward forces, elastic recoil and surface tension, are opposed by the elasticity of the chest wall pulling the thorax outward. And when we have two forces acting against one another, we go back to our picture here. If I have this chest wall pulling outward and I have surface tension and elastic recoil acting inward, that pull in that space is going to cause a negative pressure. Anytime we increase the space without decreasing the substance inside that space, that drops us into a negative pressure. So the intrapleural pressure is a negative pressure, and the value we assign to it is -4 millimeters of mercury. So this pressure is always negative because of that constant pull of those forces. So intrapleural pressure, always negative. If this pressure should become positive, that means we no longer have a pull of the thorax pulling on the lungs via the parietal pleura, and the elastic recoil and surface tension acting inward on the lung, and then that would cause the lungs to collapse. So intrapleural pressure must always be negative or the lungs will collapse. Very important concept. When we see that happen is when we have a pneumothorax. If we have any type of breach that punctures this parietal pleura and causes air to leak into that space, again, we call that a pneumothorax. Pneumothorax means air in the chest, and that is going to cause a positive intrapleural pressure and cause that lung to collapse. The way we correct that is with a chest tube, where we put a tube into that space, we apply a negative pressure, and that will allow those lungs to expand. And again, atelectasis, that term is for a collapsed lung. So pneumothorax leads to atelectasis. The next pressure we're going to talk about then is intrapulmonary pressure. Intrapulmonary pressure is the pressure of the air inside the alveoli. And when we talk about that pressure, we just set that pressure equal to atmospheric air. So atmospheric pressure at sea level, the air pressure at sea level is 760 millimeters of mercury. So when we are not breathing, when we're in between breaths, we say that the atmospheric pressure is equal to the pressure inside the alveoli. So we give that a value of 760. And then if we say that the intrapleural pressure is less than that because of the stretch of that space of those opposing forces, we give that a value of 756. But to keep things simple, we set the atmospheric pressure at 0 just for comparison purposes. So then we would say the intrapulmonary pressure is also 0 between breaths. They're equal, there's no movement of air. And the intrapleural pressure is -4. So it's 4 millimeters of mercury lower than 0. So we just use these simple numbers to kind of just make life a little easier, not deal with the 760 value. So if we look at this pressure, this intrapulmonary pressure, the pressure inside the alveoli, it would be highest at the end of inspiration when we have the maximum amount of air in our lungs at the end of an inhale, and it would be lowest at the end of an exhale when we have the least amount of air in our lungs, because it's the air particles that cause the pressure, which is the force against the walls of a container. So when we have the most air in our lungs is when we would have the highest intrapulmonary pressure, and when we had the least air at the end of exhalation is when we would have the lowest intrapulmonary pressure. And if we look at the intrapulmonary pressure, we're going to see it moving with, or changing, with the movement of the thorax. So there's a brief video here that talks about how those pressures change as the volume of the thorax changes. So in looking at this animation, we saw that during inspiration, as the thorax is expanding, that is causing a drop in the intrapulmonary pressure. So during inspiration, pulmonary pressure, intrapulmonary pressure is less than atmospheric pressure. That causes a difference in pressure, and air flows from high pressure outside the lungs to lower pressure inside the lungs. And what stops that flow of air into the lungs is when those pressures become equal. So the changing volume of the thorax causes a drop in pressure during inspiration, which causes air to flow from high pressure outside to low pressure inside the lungs. So during inspiration, the intrapulmonary pressure is less than atmospheric pressure. And when those pressures become equal, that's the end of inspiration and air no longer flows. Then when we exhale, when the muscles of the thorax and the diaphragm relax, that causes the chest cavity to decrease in volume, which will increase the pressure, the intrapulmonary pressure. So during expiration, the intrapulmonary pressure is greater than atmospheric pressure, and that's going to cause air to flow from inside the lungs to the outside of the lungs. And then at the end of expiration, what stops the flow of air out of the lungs is when those pressures then become equal. So the driving force of air in and out of the lungs is pressure changes. And what causes the pressure changes are the muscles that expand the thorax. So if we look at the two active muscles that are active during the inspiratory process, it's the external intercostals and the diaphragm. And the action potentials to those muscles are originated from the medulla. So the part of the brain that controls the contraction of those muscles is the medulla oblongata, and the pons works with the medulla to set the rhythm of breathing, switching between action potentials, activating the muscles of the thorax and diaphragm, and then inhibiting those action potentials or those neurons serving the external intercostals and the diaphragm. So going back to our PowerPoint then, this intrapulmonary pressure, the pressure inside the alveoli, changes with breathing. Again, it becomes lower during inspiration, higher during expiration, and air automatically flows. So we talked about the intrapleural pressure, and we talked about how it must remain negative. So there's another type of pressure across the lungs, and this is called the transpulmonary pressure. And transpulmonary pressure just describes the pressure across the walls of the lungs. So to calculate transpulmonary pressure, we just take the pulmonary pressure and subtract it from the intrapleural pressure. So this is a pressure that, if we look at our diagram here, transpulmonary pressure is always positive, and that helps keep the lungs inflated as well. So we find that the larger the transpulmonary pressure, the larger the size of the lungs. So that just means that when we're looking at the end of inhalation, for example, when we have maximum intrapulmonary pressure, that's when we're going to see the largest transpulmonary pressure. So it's just the pressure across the wall of the lungs, and the greater the transpulmonary pressure, the larger the lungs are going to be. So again, looking at some of the issues that we see that brings people into the hospital, atelectasis is that lung collapse, and when we don't have enough air in the lungs to keep them expanded, then that water on the inside lining of the alveoli will cause a collapse of those alveoli. So it's really important that we keep the airways open, and people with advanced lung disease due to chronic emphysema, asthma, pneumonias, they're at risk for lung collapse because there's not enough airflow to keep that intrapulmonary pressure high and keep those alveoli expanded. And anytime you have a wound, like I said, that interferes with that pleural fluid and that negative pressure inside the pleural cavity, we're going to see pneumothorax, which we have a positive pressure instead of that negative intrapleural pressure. And stab wounds, gunshot wounds, surgeries, those are some examples of things that could cause a pneumothorax. And again, it's treated with a chest tube. So volume changes are what cause these pressure changes inside the lungs. So when we look at the order of steps necessary to bring air in and out of the lungs, it has to come as a result of a change in volume. So volume changes occur first, and what causes those volume changes are the muscles of the thorax and the diaphragm. So we talked about the active muscles during inspiration that receive an action potential to stimulate the inspiration process. That's the diaphragm and the external intercostals. So we can see how these pressures change as air comes into the lung. Remember, the volume of air that we breathe in and out is called tidal volume, which is about 500 milliliters in a healthy young adult male is usually the reference that we use for a lot of our values for physiology. But again, if we look at when we're inhaling, we're going to see the pressure inside the lungs drop because we're changing the volume of the lung, making it bigger. Air flows in, and at the end of inspiration, as we exhale and decrease the volume of the lung, we're going to see an increase in that pressure. So looking at factors that we have to overcome to allow this pulmonary ventilation, which means that we're trying to bring air into the lungs. Some factors that would make that difficult would be resistance in the airways. So depending on the size of the airways, there's going to be some resistance to that flow into the lungs. So if someone has asthma, for example, those bronchioles are inflamed and constricted, and that's going to increase airway resistance. Alveolar surface tension, we said, is due to the water molecules on the inside of that alveolar inside wall, which is going to want to cause the alveoli to collapse as water likes to form water droplets and attach to one another via hydrogen bonding. And then lung compliance. So the lungs want to, as they adhere to the chest wall, that causes resistance to the lungs to reduce in size and cause or increase and